Hi, my name is Jonathan Atkins. I'm an MCC nursing student, and today we're going to do my teaching project entitled CO2 Monitoring or Capnography. Before the class started today, we took a pre-test, and as the class goes on, we're going to answer the 3 questions from the pre-test, and at the end of the class, we're going to do a post-test, and it's going to, hopefully you'll have learned something to be able to answer those accordingly. We're giving out some handouts of the different types of waveform capnography that there are, and then exactly what you're looking at in that waveform, and we're going to explain a little bit of that today as we talk about this. So let's get started. So today we're going to be talking about end-tidal capnography that monitors CO2. Well, we all know CO2 is our byproduct from oxygen exchange. So if we all take a good deep breath and we all exhale, as we exhaled, we just exhaled CO2. So end-tidal capnography is going to be the way we monitor what we exhale and how much of it we exhale. So some quick normal values. When we take in our oxygen, we take in that good deep breath and we expel it, we measure this, and the measurement that we want you to be between 35 and 45 milliliters per deciliter with CO2. And that measurement lets us know the norm. It lets us know that you are having adequate tissue perfusion because you're having the correct oxygen exchange. So how do we measure CO2? Well, there's a couple of different ways we can measure CO2. We can do it through a nasal cannula. So everybody's familiar with the nasal cannula. We put that on, the little prongs that go in your nose. It's got a little reservoir, and then it hooks into a monitor. And that monitor will give us a waveform. Another way that we can do that is through when you're intubated and we have an ET tube. So there's the tube that's in your throat, a little plastic clip clips on top of that. A little hose runs to a monitor and it'll give us a waveform. So let's talk about a few things. So now I know that CO2 is my byproduct of oxygen exchange. I know that I've got some ways of monitoring. So how can this benefit me as a nurse? So the greatest thing about it, we're going to talk about that I'm the patient that came in, you've put me on a nasal cannula, and now you see a waveform. Well, how can this help me as a nurse? I need to be able to understand this waveform, so let's talk about it. So there's 3 different phases, well technically 4, of the waveform. So we're going to have this first phase. It's called phase 0. Phase 0 is our deep breath. Everybody take that deep breath again. Okay, we're all at phase 0 right here when we take a deep breath. As we start to get to the end of our deep breath, we sink right here at phase 1. Phase 1 is when we get to the bottom of that deep breath. So right there, I'm at my phase 1. Now, as I start to exhale, I enter phase 2. The beginning part of phase 2 is the very start of my exhale. And what I'm exhaling is my dead space. So our dead space, real quick, is going to be our bronchioles, our trachea, and it's just the volume of air that isn't moved continuously because there's nothing to propel it out. It's not in our alveoli sacs, it's just the dead space. So a real quick analogy is I have a hallway and there's no air movement. It's just a dead space in there until I open one door at the end and one door at the other end. Now I've created a draft and I can expel that gas through. That's where we're at right here. I'm at the beginning of the expulsion of gas through that dead space. So then we move from the dead space to phase 3. So when we go to phase 3, we all take that deep breath and we all start to exhale. As I do that big exhale, I enter phase 3. Phase 3 is going to measure my CO2 from my alveoli. That's where the gas exchange happened. That's where my O2 hopped off into the blood. My CO2 hopped off from the blood back into my alveoli sac so that I could expel it out. So I've entered into a phase 3. At the end of phase 3, we start all the way back over again with phase 0. We do that with every breath. So I've been talking for a few minutes now, so I've done that several times right now. Okay, so we have our nasal cannula on and we're monitoring our patient. And we see these perfect little waveforms. This is what we want to see. This is great. Now, also on the side of our monitor, it's going to give us our reading. And it should hopefully show us 35 to 45. That's our normal range. That's what we're looking at. That's what's going to let us know our patient has adequate oxygen exchange. With that, we know that our tissues are perfusing correctly. So we have our normal waveform. So let's talk about a few problems and how the nurse can recognize these things. So I have my nasal cannula on, and let's say I have COPD. This is normal, so me and you would be normal, but now I have COPD. So my waveforms may look what's called a shark tooth fin, a shark fin. So we're here, and we're here. And what this is we have an increase of CO2 here and here, because we all know with COPD, I can't expel my CO2 as well as a normal person would because I have air trapping. My alveoli sacs are expanded much larger than they should be, so I have a buildup of CO2. So this is one good way that we can really do a quick diagnostic of, I put my patient on my nasal cannula, their stats come up, their capnography comes up, and I'll look up there, they're not normal, they have what looks like a shark fin. Well, I can kind of air that this may be a COPD related problem. So that's one way. Another way that this could help out the nurse is, let's say that we're in a PACU or we're in an ICU or CCU and our patient's intubated, and we have our normal waveform pulling up because we have our ET tube. It has the little piece on it that we're able to monitor our end-tidal CO2. We have our normal waveform. We have our normal values of 35 to 45, and we're watching our patient. So one thing that we have to worry about is the tube coming dislodged or the patient extubating themselves by accident. So how can we know that? Well, we have them on a pulse ox, and we would like to think that, oh, if the tube comes out, our pulse ox is going to start to go down. We're going to go from 100% down to 70. And theoretically, yeah, we will, but it's going to take a few minutes because we all know oxygen has to start from here, pump all the way through the body to come out to here. This is our longest point. So it's going to take a few minutes for that to show. Not with CO2 detection. If I have an end-tidal CO2 detection, I have my normal waveforms. Well, kind of normal. I can't draw. So we're normal, and then all of a sudden, I go flat. Well, the reason I go flat is because my patient has just dislodged their tube. Somebody has dislodged their tube. He may have coughed. There may be some kind of malfunction. But I know the tube is no longer in the lungs because where else in the body can I have CO2 exchange? Nowhere. So you have two holes. You have an esophagus and you have a trachea. If your trachea is into your lungs, your esophagus is into your stomach, and I just pulled it out, I can know right now that I'm no longer in my lungs. I know that oxygen is not going to be perfused because I do not have the delivery system there anymore. The tube is out of the trachea where it needs to be. So this is an immediate reading. So as a nurse, this is the best thing I can have for my intubated patient, to know that they're getting the best standard of care, because I know they're getting perfusion. Uh-oh, I've got a big problem. I need to call somebody. I need to do the protocols within the hospital that are in place. Also, the way this can really benefit the nurse, apparently the blue ink doesn't erase, is let's say that our patient has went into cardiac arrest. Now, if our patient's gone into cardiac arrest, we're doing CPR on this patient. How can this benefit? How can end-tidal capnography benefit the patient in cardiac arrest? It can measure our compression rate. It can let us know if our compressions are doing the best that we can do. They're doing the best for the patient, because it's going to allow us to measure the CO2 exchange. If I'm compressing your chest enough, I should be compressing your heart enough to move blood into your lungs. We ventilate. Your lungs then exchange gases because I'm moving your heart for you. I should be able to measure that with my CO2, my end-tidal capnography. It's going to measure the CO2 that's coming out of you. So the way that's measured is when you're doing CPR and you have somebody intubated, American Heart Association recommends that you should have a CO2 reading of 10 to 20. That lets us know that you're having adequate CPR being done on you. Adequate CPR is going to be the best chance of survival for your patient. So what's that going to look like? Well, you have your monitor, and let's just say, for instance, it goes 50, 40, 30, 20, 10. This is our numbers. This is where we're supposed to be. We have our waveforms come up, and we're right here. Well, I know that about right there is 15, so I'm doing adequate CPR for my patient. Now, if it's really low, let's say it's not even showing, well, I need to know I need to press harder and deeper. If it's really high, I may not be allowing the heart time enough to retract and fill back up with blood. I'm going too fast. So this is the best way for me to measure my CPR. This is going to be the best thing for my patient. Also, if we're doing CPR on our patient, it's always kind of that weird thing of, do you feel a pulse? Because we all are doing CPR, our adrenaline's through the roof, our hearts are racing, and we go, I don't know, do you feel a pulse? We all kind of sit there for a second. This can help us aid in that. The reason is, let's say we're doing CPR at 10 to 15, then all of a sudden we have a huge spike. Well, I know good and well, I've been doing this for 20 minutes, I ain't doing this. There's only one thing that can do that. We have a heartbeat now. Your body's starting to work for you. So this is another great tool of how this can benefit the nurse in the ICU, CCU, PACU setting, because we're sitting here looking at our patient. We're getting a live feed of oxygen and gas exchange in your body. This is giving us a live feed, which is going to be the best thing for our patient. When we do see this, we then know that we have a heartbeat bag. We know that we can start down a long list of things that we can do for our patient. End-tidal CO2 is a very easy thing to monitor. You got to have the correct equipment. That is the drawback. It used to be pretty expensive. Now it's becoming a standard of care, so the price is coming down. You're starting to see it now in your all your EMS services. You're starting to see it in your ERs and ICUs and CCUs. And this is the best thing that you can have for your patient, because it's literally giving you a live action shot of gas exchange to your tissues right here. And if we can do that, if we can keep you oxygenated, we can keep you perfused, it's the best possible outcome for your patient. I hope you did learn something today. This is going to be entitled, for this information, this is end-tidal capnography, or waveform measuring. I hope you learned something. And this is it. High five. Done.